Hello. Good morning, good afternoon, good evening. We just started the webinar, so I see we have folks joining. So let's give just a moment and make sure that everyone coming in is able to be admitted and access. But yeah, welcome to FP 2030 2024 measurement webinar. We're happy to have all of you here. We'll get started in just a moment. Okay, wonderful. I see people are starting to introduce themselves in the chat. We're still seeing a lot of people coming in, so we'll just take another beat, but we'll start very shortly. So in the meantime, please feel free to go ahead and introduce yourself in the chat. We're excited to see who's joining and to see from where in the world you're joining. So please, as we get started, please share. And glad to see that the chat is working. For everyone who is currently on, this will be a very interactive webinar, so we hope that the chat is active. Okay, I think we can go ahead and get started. So welcome. Good morning, good afternoon, and good evening. Welcome to today's webinar. This is FP 2030's 2024 measurement webinar, Past Progress and the Future of Family Planning Measurement in an Evolving Landscape. We are so excited to see a great turnout already, just minutes into today's webinar. And I see there is representation from across the world. I see some partners joining. I see some new partners joining too. So we're very excited to have everyone. I will be reviewing some housekeeping and setting the scene before we get into our opening remarks and into the content for today. So my name is Althea Wolf, and I'm the Senior Associate for Data and Measurement at FP 2030. I'll be taking us through some rules and some housekeeping, and then turning it over. So if we could go to the next slide, please. Hey, today's webinar is enabled for both French and Spanish translation. So please select your preferred language. We have the visual instruction here, the globe with interpretation is how you will get into your preferred language channel. So please go ahead and move into there now. Those chats will also be monitored and everything will be recorded in each language, and these recordings will be available after today. Also, please stay muted during the conversation if you do happen to have a microphone enabled. We have a very open and active chat, so we hope that people will stay engaged through that. So please, if you have questions, if you would like to introduce yourself like folks have been doing, please go ahead and do that in the chat. And if you have a question that you would like to be answered, you can also put that into the Q&A box. So we'll be recording this session and all presentations will be available broadly, and recordings should also be available in some way after today. Quickly, we will be doing presentations first from Shiza Fareed at FP 2030, Adam Wexler at KFF, and Priya Emart at Track 20 and Avenir Health. So these presentations will be the first part of today, and then we will also do a Q&A session where we try to answer questions that you've been asking throughout the webinar and also answer any new questions. And the panelists will be the same presenters. Okay, I'm going to turn it over now to Jason Bremner, the Senior Director for Data and Measurement at FP 2030. Thanks.
Thanks, Althea. What an amazing set of participants we have here. I'm looking at about 150 participants, and I don't even want to try to count up how many countries you all are joining us from, because I have seen so many across Latin America, Northwest Central Africa, East and Southern Africa, Asia Pacific. So thank you for joining us. I think for me, each year, it's always a privilege to welcome all of you to our annual measurement webinar. This year, we are talking about past progress and the future of family planning measurement in an evolving landscape. Today, I'm actually joining you from Nairobi, where I'm visiting our East and Southern Africa hub. And I just last week had a brief opportunity to join Track 20 in Kigali for their annual monitoring and evaluation officer training. So I got to see many of you. And they were actually working on preparing estimates on country family planning indicators for 2025. But today we're actually reviewing data from last year's estimates that were released in December of 2024. And we had planned on doing this webinar around January, February, March of 2025, looking back as we always do at progress. We realized that in January to March, it simply was such a chaotic moment, such a destabilizing moment, that it didn't seem appropriate at that time to be talking about our progress. But we also realized that a tremendous amount has changed since January. But at the same time, we think it's wise to review the progress or the past progress we had made so that we understand what is at stake as we respond to our drastically changed landscape in global health. Althea mentioned that today you'll hear from FP 2030, from KFF and Track 20 on insights from last year's data, but you'll also hear a bit about what we're learning about impacts, how those impacts have affected data systems, and we will try to read the tea leaves on what we anticipate moving forward. Later this year, ahead of ICFP, we plan to release our 2025 data, and we plan to also focus on impacts of funding cuts, terminations, and what that is looking like for stocks, services, and outcomes. Over the last 10 years, I've had the pleasure to work on family planning data, and it has been really an incredible journey of 10 years of improvement, of greater visibility into data systems. Just last year, we were able to release trends in domestic expenditures for family planning, looking at commodities, services, and a whole host of different subcomponents. And this, we could say, revolution in data, I hope will continue, but the headwinds are against us. And I hope that as we are struggling to determine what to prioritize, how we can move forward, that we don't lose visibility, that we don't lose a lot of these data systems, and that we learn how to use what we have better. So with that, I will turn it over to my colleagues, starting with Shiza Farid, to start looking at this year's data and what we're learning. Shiza, over to you.
Thank you, Jason. And we move to the next slide, please. Hi, everyone. My name is Shiza Farid, and welcome to the webinar, and thank you for being here. I'm the Senior Advisor for Data Analytics at FP 2030, And like Jason mentioned, I will be providing a global overview of the 2024 measurement report data release. And I'll do my best to contextualize the progress in terms of what is at stake with current and planned donor cuts. And you'll hear more about this in the next presentation. Next. Many of you join this webinar annually, so you're familiar with this graphic. The graphic details the process for 20+ indicators that we annually report on. And over the course of the year, Track 20 works with countries to aggregate and analyze their data. And then later half of the year, FP2030 works with Track 20 to produce and publish this data in the annual measurement report. Like Jason mentioned, he was just with Track 20 last week, where they're working with countries on their annual measurement report data for 2025. So our process is really meant to be bottom up, starting with the countries and ending with the data release later in the year. Now, getting into what is released for 2024. Next. This year's release contains data on 85 countries, including low and lower middle income countries and countries that have made a commitment. The data release includes a data brief, which is forthcoming, a data dashboard, next. The data dashboard features country-specific data visualizations for 20+ annually reported on indicators. On this dashboard, you can also review donor finance and domestic expenditure data. You have the ability to compare domestic expenditure expense type, so looking at capital costs versus personnel costs. This is coming directly from Track 20's FPSAs. You also have the ability to review supplemental adolescent and youth data, indicators on adolescent and youth population size, family planning use, marital and sexual activity, and key life events. The user has the ability to look at country data one at a time or compare between two countries. Our dashboard also features regional comparisons of key family planning indicators. So you can look at progress across different regions. And it also has an intra-regional comparison where you can look at country-specific progress against regional averages. Next. Quickly, here's an example of a country-specific data page with data visualizations. And next. And lastly, you can get all of these indicators that we annually report on also in the Track 20 data briefs. Their briefs are available in English, French, and Spanish. They're available both on the FP2030 website and the Track 20 website. We have also published uncertainty estimates for our indicators, which are on our website. And lastly, this year, there will also be a new data observatory for family planning data in the Latin America and Caribbean region, and this is forthcoming. Next. Now let's get into some data highlights. So on the next several slides, I will share data on global trends in contraceptive use, so staying very high level. Next. What is clear from what we've released so far is that contraceptive use continues to grow. More women are using modern methods than ever before, and shifts towards newer method continues. In low and lower middle income countries, there are almost 1.1 billion women of reproductive age, and this population continues to grow. As of 2024, more than 1 in 3 women are using a modern method of contraception, which is estimated to be around 380 million women. Next. On this graphic, you can see that in 2012, total modern contraceptive users were estimated to be around 283 million. And by 2024, this use increased to more than 380 million modern contraceptive users. That is an almost 100 million additional women that were using modern contraception in 2024 than were using in 2012. Next. The 380 million women using modern contraception and the 1.47 billion in donor financing translates to more than 143 million unintended pregnancies averted, 29 million unsafe abortions averted, and 144,000 maternal deaths averted. Next. The progress we have seen has been substantial and sustained throughout the last decade, including in the lowest prevalence countries, and this is no small feat. In 27 countries, the number of modern contraceptive users has doubled since 2012. In 2012, 13 countries had modern contraceptive prevalence among all women below 10%. Today, only 3 remain in this group. And in 5 countries, Burkina Faso, Madagascar, Malawi, Mozambique, and Uganda, the average growth in modern contraceptive prevalence for all women since 2012 has been 1 percentage point or greater. And when you look at married women data specifically, the number goes from 5 countries to 13 countries. Next. During the same period, we've also experienced rapid shifts in method mix. In 2012, implants were the most common method only in one country, Burkina Faso. But because of the Implant Access Project, reduced costs and training of providers in insertions and removals and community awareness, there has been a dramatic shift towards long-acting reversible contraceptives. Implants now are the most common method in 12 countries, the second most common method in 17 countries, and more than 1 in 10 modern users rely on implants in 38 countries. Next. So, given the current cuts to USAID and other planned cuts, you'll hear more about this in the next presentation. What is at stake? A lot. First, the gains that have been made in modern contraceptive use in the last decade, access to a wide range and even newer methods, giving people more options to meet their preferences, to switch to a method, to stop and try a new method, reductions in preventable negative maternal and reproductive outcomes like unsafe abortions and maternal mortality, and our ability to monitor progress. The data that we report on every year, like Jason mentioned, is dependent on different data systems, including surveys like the demographic health surveys and health management information systems like DHIS2 and logistic management information systems. In the coming years, our ability to monitor progress will be dependent on what is available, and Priya will discuss this in her presentation. At the same time, it is important to remind ourselves that our community has demonstrated resilience in the face of past instability. During the 2014 Ebola crisis and the COVID-19 pandemic, we came back stronger. And FP 2030 is committed to a future where individuals everywhere have the freedom to ability to make their own informed decisions about contraception. So as we are continuing this journey together as a community, we are committing to releasing an impacts report later in 2025 to quantify or qualify some of the impacts that we'll be continuing to review. And I want to thank you, and now I will turn it over to Adam, who will present on the donor finance data.
Great. Thank you so much, Priya, Jason, and it's good to see so many people joining this presentation webinar today. Again, my name is Adam Wexler. I'm Associate Director of Global Health and HIV Policy at an organization called KFF, where we are based in DC, and we focus on doing policy analysis, original reporting on health policy issues. I'm part of the global health team and have been involved in an annual analysis to track donor government funding for family planning for over a decade now. What I'm going to do, as in past years, is highlight the data from our most recent report. But as Jason mentioned, try to go a little bit further, provide a brief overview of what we know currently is happening with the US and other donors, and assess as much as possible what that means moving forward. So let's go ahead and go to the next slide and begin. Again, I'm going to start with the most recent report and then highlight some of the administration actions and what their implications are from the US government, and then look at the other donors, and then move forward on what that might mean for funding from these governments in the years to come. Next slide. Okay, before we get into the data, I just want to mention briefly that what we do is look at the funding from all the members of the OECD DAC. We are focused on bilateral funding for family planning activities, as well as an FP-adjusted share of those donor government contributions to UNFPA. And I want to thank UNFPA for working with us to calculate and understand that share. Next slide. In 2023, our most recent report, which we also released in December at the same time as FP 2030, We found that donor governments provided approximately $1.47 billion in funding for family planning in 2023. That funding represented an increase of about 7% or just over $100 million compared to the previous year, which totaled $1.37 billion. And it was a return to prior year levels. 2022 had been a decline, but it was still below the peak that was reached in 2019, which was $1.58 billion. Looking more broadly over the period since 2012, funding has generally risen, but there have been fluctuations. Most of that funding that we track is bilateral funding. In 2023, it totaled about $1.4 billion, or 95% of the total. With the remainder, $70 million, or 5%, was for multilateral contributions to UNFPA's core resources. Next slide. So this slide simply shows the trend over time, the totals that we've been collecting over the years. And what you can see is there were some increases over the period. There were some fluctuations, some of which was due to the rise of the US dollar globally. But generally, you can see this trend line going up until more recently, it's somewhat of a flat period here in the last couple of years. Next slide. In 2023, what we found is that the overall increase compared to 22 was largely the result of increased bilateral funding. Multilateral funding was declined slightly. The US was the largest donor, accounting for 40% of the total funding, followed by the Netherlands, the UK, Sweden, and Canada. Over the entire period, in most years, the US and the UK have been the top two donors. It's just been in the last 2 years that the Netherlands has moved to the second spot. But when you remove the US and UK from the overall totals, what you see is the other donors have had been increasing pretty consistently over time. There have been fluctuations, but they've been driving increases over the period. Next slide. This simply demonstrates the breakdown by donor in 2023. And again, as you can see here, the US accounted for 40%. The next donor that was the Netherlands and the UK. Those top three donors account for 70% of total donor government funding for family planning. When you factor in the top five and include Sweden and Canada, you're looking at 86% of the total. Next slide. So now, as I mentioned before, let's take a look at what the trends are when you remove the US and the UK. That top line, the flat green line, that shows US funding. And I'm going to get into that in a little bit more detail later in the presentation. But as you can see, it's basically been consistent over the entire period at about $600 million. The bottom line, the lighter blue line, that's the UK. As you can see, there were some fluctuations also over the period, but in recent years, the totals have been below where they were in 2012. So now let's focus on that middle line. If you wanted to extrapolate, you see it's kind of an upward trend. There have been some ups and downs, but really those donors have been the ones that have been increasing over the period. Next slide. Okay, so that was our prior report with very different circumstances. That data is now from almost 2 years ago. So let's look at where we are, and we'll start with the US. Next slide. Since the Trump administration came into office, as I know you're all aware, there's been a number of actions that have impacted the entire US global health portfolio, particularly family planning. So I just want to cover what some of those actions are and briefly mention the impact. One of the first things that occurred was a freeze in foreign assistance funding, a stop work order. Stopped all family planning, programming, and services, including procurement and delivery of commodities. The administration then issued a waiver to allow life-saving services to continue, but family planning was specifically prohibited from being included in that waiver. Then we saw the dissolution of USAID and the reorganization and incorporation of elements of USAID into the State Department. As the primary implementer of US family planning programs and broadly speaking, US global health efforts, this has obviously had a very significant impact on what the US can do globally. Then we heard of the canceled awards and contracts that occurred. We at KFF did an analysis of those cancellations, focusing on USAID, and found that 85% of the awards that included family planning as the primary component or an aspect of it were canceled. We also have policy restrictions that have been put in place, and that's the reinstatement of the Mexico City policy and the prohibition of funding for UNFPA. And most recently, in the last month, the president has submitted his request to Congress for funding in 2026. And I'll get into this in a little more detail in just a moment, but the U.S. situation is very unique in that the president submits a request, Congress decides the amount. It's a debate. Long story short, the president has proposed to just completely eliminate all family planning funding in 2026. And then coming this week, we've been informed that the administration is going to submit a rescissions request to Congress. And what that means is they're going to ask to cancel funding that was provided in previous years. And it could potentially include funding that was given by Congress for family planning activities. So all in all, a lot of difficult actions and decisions were made and are impacting what we're doing here. Next slide. So what does that mean? And it's just important to highlight once again that the U.S. accounts for 40% of total donor government funding. Next slide. Let's unpack a little bit more about what that means, because the U.S. situation, as I mentioned earlier, is a bit complex. Each year, Congress decides overall funding levels for the U.S. government and what it can spend. And for the past over a decade, the U.S. Congress has said, we are providing about $600 million for family planning. It is stated in U.S. law. And once that is done, the administration is supposed to take that money and provide it for those activities, but they have several years to do so. So while we highlight this flat line here, the money actually getting to the ground and out the door may occur over a several-year period. Next slide. This is what that looks like. So this additional line here shows how much money is going out on an annual basis. And the reason for those fluctuations is because maybe there's a new contract in place, maybe there's a new program in place, and it just takes time to get that money out the door. So one year you might have a high level of funding going out, and the next year a lower level. But ultimately, that $600 million has been historically spent over a multi-year period. Okay, so next slide. So what does that mean? That means, or what does that translate to? What is the U.S. doing for family planning activities? And this is just a fraction of what is being provided. The U.S. provides staffing and infrastructure, so salaries, facilities improvements, technical assistance, trainings, program design, information systems, data collection, the DHS, as mentioned earlier, monitoring and evaluation, supply chains, product procurement and delivery. A whole host of services and activities stopped, gone. And now, just to highlight what that means as far as impact on human lives. And I want to highlight the work done by Guttmacher Institute, I'm sure you're all aware of, but it's important to really highlight what the cost is here to the people that we serve. And what Guttmacher found from that U.S. investment of about $600 million a year is that 47.6 million women and couples are served, 17.1 million unintended pregnancies are averted, and 34,000 maternal deaths are prevented. And that's just a fraction of what they found, and that's on an annual basis as a result of the U.S. funding. So next slide. All right, so that's the U.S. situation. I'm sure there's a lot of questions that we can get to at the Q&A, but let's also look at what the other donor governments are doing. And so next slide. Just want to highlight again who we're looking at. I mean, if we look at the top three donors, the U.S., which we've covered, but then the Netherlands and UK, combined, these donors account for 70%, and Sweden and Canada, 86%. Next slide. We know that there have been announcements from the UK and the Netherlands and Sweden of reduced ODA. Whether that translates to reduced funding for family planning, we don't know yet. That is still to come, but in all likelihood, probably yes. Other donors that we track in the DAC have also announced reductions. Belgium, France, Germany, and Switzerland. And I want to highlight this is pulled from work done by Seek Development. They have an excellent donor tracker and have actually created a budget cuts tracker where you can see what the latest data is on the various announcements from donor governments. I highly recommend taking a look at that. Next slide, please. So what does all this mean for 2024, which is already behind us, and beyond? Next slide. In all likelihood, 2024 is probably going to be at our prior historical levels. We don't anticipate any huge fluctuations because a lot of the stuff impacting family planning has only happened in the last couple of months. So what do we think for 2025? In all likelihood, there will be significant declines, largely attributable to the US, but also potentially due to some of those other donor governments decreasing their support. But let's look at the US just one last time before we move forward. There's a lot of uncertainty still. I see Jason brought up a great point to talk about rescissions, just to highlight that a little bit more. And as I mentioned earlier, US Congress provides a certain amount of funding. The administration then disperses that over time, but they have several years to do so. Well, the big question now is the funding that was provided by Congress in 2024, which could be spent in 2025 and 2026, will they actually do that? We anticipate they're going to come to Congress and ask to take that money back and not allow that to go out the door. So that means potentially funding provided last year that should be spent this year is not going to happen. In fact, at a recent hearing of Congress, where Secretary Rubio was testifying on their funding request for 2026, he was specifically asked this very question: what are you going to do with the funding we provided for you last year? And his answer was, we are not going to spend it. And then he continued by saying, we're not going to spend that on the activities that we supported before. We're going to do different activities. But the question is, if they do that, what exactly are they going to do? And with all of the cancellations of contracts, the dissolution of USAID, how are they going to do that? Those are the questions, and that's a lot of uncertainty moving forward. So are we losing funding that was provided in prior years? If not, how is that going to be spent and what on? Also, what is Congress going to do? Are they going to support the rescissions that the administration asked for and allow cuts in funding from prior year amounts? Or are they going to push back against that? We don't know. Also, are they going to support this recent request from the administration to completely zero out family planning funding? We don't know. We'll learn a lot more in the months ahead. We will be releasing our next report prior to CFP, and we'll have a much better idea of what the landscape looks like at that time. So with that, I want to just thank you for allowing me to cover all these various issues. I'm happy to answer questions on any of these elements, either now or afterwards. But before I hand it off to the next presentation, I do just want to thank a few individuals who, some of the things I highlighted, there was work done by a group that includes Reproductive Health Supplies Coalition, Avenir Health, FP2030, Guttmacher Institute, JSI, and UNFPA to really kind of assess a lot of what's going on. And their work needs to be acknowledged, and I want to thank them for all that. And so with that, I'll hand it over to Priya to take the next presentation. Thank you so much.
Thank you, Adam. And just for everybody's information, it was Shiza who presented earlier. So hello and greetings from Track 20 and the entire Track 20 team. My name is Priya Emmert and I'm the Deputy Director of Track 20. Today I present on rapid intelligence that Track 20 gathered from multiple FP2030 countries on impacts on information systems, something that Adam just very quickly highlighted on the types of impacts that might be felt with the USAID cuts. For this presentation, Gabrielle Appleford, Track 20's consultant, worked with me on this assessment. We gathered information from multiple Track 20 government counterparts, both at the leadership and the data expert levels. Next slide. So this presentation is really a preliminary look into country responses to USAID cuts. We did part of this work in April and part in May. And the focus here is on learning about the immediate and short-term impacts on information systems from a government perspective, with a short look at an example of resilience on data, followed by a summary of impact from the loss of DHS surveys on FP 2030 reporting and country monitoring. Next slide. Early in mid-April, Track 20 collected some rapid intelligence using in-depth interviews from government FP managers and data experts on the immediate and sort of bubbling impacts from the USG withdrawal. And in May, we had Track 20 focal points respond to a survey on these same impacts. The impact questions that we focused on data, data systems, commodities, services, prioritization shifts, if any, and government plans to mitigate. In this webinar, I'm only going to focus on the early intelligence we've obtained on impacts for information systems such as LMIS and HMIS, and do note that all of this information will continue to evolve. So who was asked? All Track 20 countries that participate in the annual training workshop. Indeed, we just finished one, it was last week. And of these countries who were asked, 17 countries responded, and you can see slightly more Francophone and Anglophone, and the majority of these countries reported major impacts on their information systems and data in the immediate and near term. Next slide. Now the headlines from the in-depth interviews that we conducted and the surveys. Headlines from the survey are grouped by data systems and data for decisions. In terms of systems, we heard that routine health information systems were impacted in the immediate aftermath of the USG withdrawal, and the scale was quite impressive, with data systems down for a week to months, to impacts on servers, licensing fees, HR, because their staff seconded at national and subnational levels, as well as tools that were used for reporting in either of these systems. We heard also, as most of you know, that countries also saw an immediate stop to ongoing surveys from data collection to analyses to planning for a new survey in the immediate future. So for some countries, the blow to data and information was quite significant. From what we heard, the impacts will not only be felt in operations in the near term, but also the ability to monitor and report on goals, including those on the SDGs. Next slide. Headlines from data for decisions. We also heard that program managers were asked for data and to provide details on funding cuts by activity. Data was requested by senior decision makers like Director Generals of Health or permanent secretaries, who themselves were being asked to produce lists of priorities and program activities for Treasury departments. It is fair to say that going into these discussions, family planning featured only as a very minor part, if at all, within the larger concerns relating to life-saving interventions like immunization, HIV, and TB. That is what we heard over and over again in our in-depth interviews. Some countries have undertaken rapid assessments, completing mapping exercises to understand areas of vulnerability. This includes technical, geographical, and programmatic vulnerabilities. Program officers have also received requests on shifts that they might be seeing already in routine data trends, shifts in volumes dispensed or services or visits made to facilities, along with those activities and funding gaps. And we anticipate that as these cuts are more deeply felt, at the service delivery level, the requests on impacts from routine data will simply increase. It's also interesting to note that in the initial aftermath, no metrics were specified on how programs should choose to reprioritize. Programs were reporting on a range from trying to obtain funds to do the same activities and investments as before, to the other end of the range, which was to stop all activities that were USG funded, irrespective of impacts on specific populations. Okay, so now I'll switch to what we heard from our first survey. Next slide. Survey responses suggested that LMIS systems experienced more shocks than DHIS2 because it appears that partners were managing the logistics system, including for family planning in many countries. It was clear that populations in conflict, especially those with specific programs for high need, hard to reach areas, suffered the most, as the government had no other partner or resources to quickly pivot as the situation demanded. Their immediate and current needs from the survey seem to be most in jeopardy. As you might imagine, countries like Nepal, with a high dependency for system support, also suffered as trained staff and operational functions were disrupted for family planning as well as for other essential health products. For countries who had begun a journey into building data ecosystems to connect disparate strands of data through EMRs or digitalization, HIE, even routine HMIS tool changes, all these abruptly ended, and these kinds of investments may be hard to restart, according to the participants. Most respondents focused on the supportive activities which were being affected. I think that was also quite interesting, especially not being able to conduct activities like DQAs, supportive training, meetings, tool reviews, other such support to the program. And finally, since stockouts can be monitored, should be monitored, using LMIS and sometimes DHIS2 data, we should anticipate small impacts on these systems for monitoring stockouts and the ability to report on them. Next slide. This slide is really, it's packed, but it's a quick summary of the survey country responses on information systems using traffic signal colors to organize them. Countries in red, for example, reported the most disruption in their data and systems. And here you see DRC, South Sudan, and Nepal, and countries in that amber color. Most of them were in that in-between part. And I think it was we probably should expect to see some of them move in the red direction. Countries in green were green largely because, as you see here, they were not a USAID priority country and had very little impacts to show for it. Okay, next slide. So now I'm going to quickly turn to an example of resilience in data from Ethiopia. Ethiopia had invested in building out an e-health architecture. So they started this work a little while ago, in I think 2023, perhaps even earlier, to enable health facility-related data to be shared across platforms, including HMIS. So the Master Facility Register is what we see as one example of resiliency, and it's also one of the shared services on this platform. And all programs were sort of working on this e-health architecture, but family planning was particularly drawn in because of significant problems they were experiencing in inventory management and inefficiencies and through overstock, understock, and procurement impacts that followed. Much of the disconnect they discovered was between the different and missing facilities in their DHIS2 system, their LMIs, and their emergency preparedness and response systems, information systems. So what they did here was to systematically review these facilities to make sure that the names, the location, the actual missingness of these facilities were found and carefully removed when it was needed or aligned across these different systems for reporting FP data. And this way, they were preparing the way for what is important in data quality and availability, which is about data triangulation and accountability. All facilities, including private facilities, are assigned a unique ID georeferenced, provided with passwords to facilitate electronic data reporting and processing. Next slide. The key takeaway, I think, here is about getting ahead of the private sector, getting efficiencies done in the spirit of integration. And we see a few other countries, quite a few other countries, moving in this direction and may indeed, and even if they're not there yet, I suspect that they will be sort of pulled into developing integrated solutions in response to the cuts for USAID. How family planning fares in terms of the indicators, in terms of the information that's being collected, really will depend a little bit on how prepared family planning programs are for accountability and for governance. So in this instance, the Federal Ministry of Health really effectively used funding from the World Bank and the Global Fund for the health system strengthening and developed an integrated solution. And their systems lens was not a vertical program, but primary healthcare. And the other interesting part was that it allowed for honest reflection of missing and mislabeled facilities within the system. I think what I've seen at least, and many of my colleagues from Track 20, from the Track 20 countries will agree that this kind of honest reflection is much needed, but not there very frequently. What they found was that reporting in both sectors had improved substantially and can be tracked. And they were able to bring in the digitalization through the tracker for both sectors. And by that, they mean commodities as well as the services sector. And most importantly, family planning has a seat at the table, was actively involved in the initiative. Next slide. I'm now going to turn to the final bit, which is on what's going to happen to annual monitoring. So we see top-line indicators are already models, so they will continue to be produced annually. We do not expect to see impact in the first few years, had surveys released last year. And the hierarchical model pulls from country, sub-region, region, and global data. So we expect after a few years, that uncertainty around these estimates that Shiza presented earlier will increase. We also expect that the role of health information systems will grow. Countries can already, as you know, include their service statistics or their DHIS to HMIS data in these modeled estimates if the quality is good enough. We simply expect that this data will become even more important in the next few years, and we're actively encouraging countries to carefully review their data. Final slide. So what about other impacts that come from the loss of DHS surveys? So some indicators come from secondary data analysis on survey data sets. These will be seen starting next year when we'll have fewer new surveys. So the 4 indicators that we highlighted here, discontinuation, method information index, which is signaling quality, decision-making, and age disaggregation are those indicators that will fall off. They might be provided by other data sources, but we think it'll take time, and more importantly, they may not be standardized across countries. So in terms of discontinuation and routine data, quite a few countries have indicators on this, but the quality is not very good so far, and potentially could improve as electronic electronic client records becomes a bigger thing, if possible. The method information index is simply not possible because it's based on a woman's response, as is decision-making. And age disaggregation, many countries have introduced some type of age disaggregation, but may be limited to just sort of family planning uptake or certain specific methods that the program might be interested in. So thank you very much. And now I'm going to turn it back to FP2030.
Thank you, Priya. Thank you, Shiza. And thank you, Adam, for giving us insights into the past data, as well as what we're learning about today's current challenges and thinking about the challenges ahead. This is a great time for all of you who have been participating to continue to ask questions. You can ask questions using the Q&A button, and you will see if you click on that, there's an opportunity to ask questions there. We'll be answering some of those just through chat, if it's a quick answer, and you can see the answers there in the Q&A. Or you can ask some questions in the chat as well, and we'll do our best to to respond to all of those. I do see a question, a simple logistics question. There were questions about whether recordings will be available or can we have the presentations. We will not be distributing the presentations themselves. The recording of this webinar will be available through FP2030's YouTube channel. So don't be afraid to ask questions. And we have quite a bit of time. So I'm going to go ahead and moderate some of those questions. And if you can stop spotlighting me and we can bring it back to all of our participants. Thank you. So I'm going to start off with a question here for Adam, which was, Adam, there was a question about reasons for fluctuations in the US funding over the years. They were referring to that slide you showed with the ups and downs. Can you say a bit about those fluctuations and reiterate how that relates to appropriations? Thanks.
My pleasure, and thank you for that question. It's a really good one because the U.S. situation is very complicated, and so basically the U.S. Government, Congress, sets funding each year for family planning, and for the last decade, it's been almost $600 million. That's set in law, and then the administration has several years to spend that money. So of that, almost $600 million will be spent on family planning activities over a multi-year period. The reason for the fluctuations is sometimes the money just doesn't go out before the end of the fiscal year. You might have a huge disbursement of funds on the first week of the new fiscal year that shows a huge increase. It's just a timing issue of when the money is going out the door. And that could be just because of a new project or a new contract. So this is across the board in all US global health activities. When we look at those ups and downs, it's the same for maternal and child health, HIV, TB, malaria. It's just a matter of when that money is actually spent. We have that flat funding. We know that that's what historically would be spent over time. The big question now is whether or not the current administration is going to do that. So again, it's complicated. I hope that provides some clarity, but happy to elaborate further if helpful.
Thanks, Adam. And while I just have you on the mic, you had talked about rescissions. I think you answered Martin's question about what could be clawed back. Congress has to vote on rescissions, isn't that right? And can you just explain whether that's just a simple majority or is there a certain number of votes that they need to get to approve a rescission?
Excellent question. So as I mentioned before, rescission. So there's all this money that's still waiting to be spent by the administration. So the 2025, almost $600 million that Congress provided, the administration is supposed to spend that. But what we anticipate is that they're going to ask Congress for approval not to spend that. So they're going to say, Congress, we don't want to spend that $600 million. What it takes, to your question, Jason and Martin, is they do need to approve that. And that's a simple majority as far as I understand. But if they don't do anything, then it just goes away. They still have to spend it. They have to take an action on that request. And we're actually going to be doing some further analyses of that once the full package is sent to Congress. And we'll be able to detail that. And I'll send that to you to share with the group, or anyone wants to reach out to me individually, please do so. And we can provide that additional information.
Thanks, Adam. All right, we'll change gears and maybe we can talk a little bit about the sources of data and how that relates to a question about trends in sterilization. I think Priya and Shiza both mentioned that we use different sources for different indicators, and method mix is an interesting one. Shiza, can you say a word about how we develop indicators for method mix? What are our sources? in how we try to track trends in particular methods, and then maybe I'll turn it to Priya for any particular trends related to sterilization in India and Nepal, which are two of the countries that have really had sterilization dominate the method mix. So go ahead, Shiza. How do we measure method mix and particularly sterilization?
Yeah, thank you. So currently the way we report on modern method mix is we rely on household surveys. So surveys like the DHS, the Mix, or PMA. And then in terms of trends, we compare from the most recent to a previous survey or one that was, more than 5 years ago, because trends in method mix don't necessarily change annually. But you can capture some change 3 years or so between surveys. And then it would be great if Pierre can also touch on some of the proxy indicators you might be able to get from the HMIS reviewing method prevalence within the DHIS2 or the LMIS systems.
I hope
Thanks,
I got
Shiza.
the
Over to you, Priya.
question, and I hope I got the question and Shiza's subsequent question properly, so do correct me. I'll start with Shiza's question about LMIS and HMIS systems having proxy indicators. So we are able to produce through our tools and through an application that we've designed for DHIS2, an estimate of modern use that we can use in modeled estimates. And that is more a growing number of countries are starting to get to able to use their routine data to inform these estimates. I think the countries have also developed some proxy indicators or the actual indicators for stockouts, for example, through their routine data. So this year, for example, in our training workshop, we were looking at the construction of these indicators and what we might be able to share with the PME working group for discussion. And some of these indicators make a lot of sense, and they may not be universal like we might have liked, but certainly are important signals for the country in terms of their capacity to monitor this. I'm sorry, Jason, I heard the part of the question on the sterilization. Would you mind repeating it? And Shiza, let me know if I've answered yours.
So this person was asking whether we see trends in sterilization, either male or female. And I know you work quite a bit in India, a country that has certainly the most dominant method being sterilizations. I know we did some analysis a few years back and wondered if you had any thoughts on that.
Right. I think I don't. Are you asking me a question from routine data or from survey data? Sorry.
What did the survey data tell us? And it was complicated, and I'm happy to chime in as well. But yeah, go ahead.
Why didn't you chime in? Because I don't think I'm really. Yeah, go ahead.
Yeah, well, I think this comes at the challenge of just using HMIS and LMIS systems to understand method mix. And sterilization is an interesting one, because when you're measuring sterilization, you're talking about women 15 to 49. So a woman could be, particularly in India, would have been usually had a sterilization early in life, could have been 20 years ago, and she still counts as a user of sterilization today. And I think the HMIS system is a good one for measuring methods that are distributed regularly. But as we lose survey data, we may lose insights into methods that people use for a long amount of time, permanent methods, or even long-term methods like an IUD, because we lose data on discontinuation as well. So just to say that it becomes more challenging without survey data to get a full picture of method mix. India is an interesting example. We could talk endlessly about declines in sterilization we saw in the last survey and why that was. But it's probably that's probably for a separate webinar. But just to say, it becomes complicated. And thank you for the question. And Priya, if you wanted to add anything to that, you're welcome.
Sure. So I think part of it is the in India anyway, part of the country does have a pretty decent handle on sterilizations in the current moment. So as you said, they're not keeping data on information on people previously sterilized and maintaining that. To mitigate against that, that is something that we try to do through using our service statistics tools. But you're quite right, there has been a decline, and there has been a greater emphasis by the government on spacing methods, specifically around, expanding the method mix, including injectables. There's been a bit of difficulty around the IUDs, as they would well say as well, especially in terms of the prevalence in surveys versus what they have been seeing in terms of the numbers being reported in routine systems. But yeah, I think that's the other issue as well is that women in India, the median age of sterilization is quite low. So that could be shifting as well, based on some of the investments that are being made by the government in other sort of congruent parts of women's health, which is around education and labor skilling, things like that, that are also having an impact on whether women are delaying their first birth, delaying the next birth, etc. So I do see a question that I did want to highlight in the, if I may, but I'll wait to get permission from you, Jason.
Yeah, let me come back to you. We're just going to kind of change gears, and we'll come back. I did see one you were going to answer. I did, and feel free, my panelists, to also type in answers to some of the easier questions. I see a question that is related to insights on human resources and as well as physical infrastructure from Duff Gillespie and Shiza. I wonder if you could say a word about some of our impacts task team work and the type of data that we're trying to collect. And are we hearing anything on human resources, physical infrastructure necessary for administering and implementing family planning?
Happy to. So at FP 2030, we have an internal task team. We're working with our hubs and reaching out to our focal points, which are made up of, formerly USAID, UNFPA, other civil society partners, and young civil society partners. We've been able to collect information on how the USAID cuts have affected their work environment. One of the questions we've asked is, have you had to lay off workers? What have been the impacts to your data systems? What are just the impacts of you providing services? And we do have some qualitative insights from that work. And Duff, I'm happy to email you separately to share some of those insights.
Thanks, Shiza. So Priya, I think that you wanted to answer a question on responses that countries were taking to these cuts. Is that correct?
Actually, I was responding to the question by Dr. Lashari from Pakistan.
I see. Yeah, go ahead.
But I'm sorry, the questions are coming and I keep trying to respond.
Go on that one. We'll bring another one back to you in a bit.
Sure. So I think the question that he asked was about the resilience example by Ethiopia and how they have integrated LMIs into other data systems. So that is an important question. And interestingly, quite a few countries are grappling with this in different ways. And in Ethiopia, basically what they did was to develop a health information exchange platform. They're still building it out, but they had this stream of data that's coming from clients, the electronic medical records from select regional health bureaus. They have data on emergency preparedness and response from those conflict regions. They also have data from the visits from DHIS to the services data and logistics data as well. And they had a lot of confusion in terms of the needs of the different regions based on which data set those regional health bureaus were looking at. So in order to improve efficiencies across, what they did was to develop a data solution to enable these different information systems to speak together. And one important way was to develop these master facility registers so that all facilities in Ethiopia, in each regional bureau, are mapped, georeferenced, and they have a unique ID. So they cannot just different names for the same facility were creating huge discrepancies in commodities obtained, distributed to that facility, and also requests coming from different systems. So this was actually really, this is going to be an important impact for the future in terms of cost, resources. This is going to help them protect the limited money that they have. So I think other countries are trying to do the same as well.
Thanks, Priya.
I hope.
Yeah, that's really helpful. And so we've talked about HMIS systems, LMIS systems becoming more important, albeit with some limitations. That assumes that that we are going to lose all of the DHS funding, right? So the Demographic Health Survey, as we know it, has been terminated. But there have been conversations about the future of the Demographic Health Survey, and there's a question here from Olenike regarding the impact of loss of DHS funding, how we might mitigate that, and a question about whether the UNICEF mix is also affected. I'll take on the DHS component of this. Maybe Shiza, you can add a word on whether we're learning anything about the mix at this point in time, and also how loss of funding to the Census Bureau might also affect all of our ability to do surveys, to census support, sorry. So Nike, there's an active conversation going on about the future of the Demographic Health Survey program. It has been terminated, and there is no sign that there will be a reversal of that termination. Several countries had surveys that were not completed, were in the field, or where all the data collection had been completed and data sets or final reports hadn't been released. And that includes Nigeria, several countries as well, Ethiopia, Malawi, Zambia, and others. So there is an effort to, I don't want to call it rescue, but to resuscitate those surveys that were completed in the field and where last efforts were needed to get the data out and available. We do expect that data will become available. I don't know when. There are still team members from the Demographic Health Survey who are working on that. Beyond that, we do not know about the future of the Demographic Health Survey. I would say that it's an active and vibrant conversation. I don't expect that we'll see any surveys in the field from a different or a similar DHS anytime soon. And so I think what we have to rely on is HMIS, LMIS models, and potentially mix in some countries. And Shiza, what do we know about mixed surveys?
Yes, thank you. So mixes, as everyone knows, implemented by UNICEF, and the US is the largest donor to UNICEF. So with all of these funding cuts, we can presume that there will be or have been cuts to UNICEF. And as such, while we have not heard about specific mix not going out into fields or being cut, it's only a matter of time if these cuts continue. I will say the mixed funding structure might be slightly different from the DHS, where it is more of a cost-shared project across countries. So it's to be determined, but expecting some impact.
Okay, thank you. So I'm just gonna look down the questions here. Priya, there was a great response from one of the colleagues in Madagascar. It has been translated for you to look at some of the impacts across Madagascar on data systems. So I think it would be great for you to just have a look at that comment. Some really interesting information there. And there are some questions on domestic resource mobilization and self-investments by countries in their health systems. And maybe, Adam, I know that this is not your wheelhouse of domestic expenditure, but I know that in terms of the overall amount of support for family planning, you had talked about that 40% of USG support for family planning of overall bilateral donor. What's the feasibility? I mean, I think Salmia asks here, the feasibility of being able to really meet the same level of funding from US government and also those other European donors who have announced ODA cuts.
Sure. And before I respond to that question, I just want to add a comment on US funding for UNICEF that Shiza was discussing before. We track US funding across the board. And in the recent request that the administration submitted to Congress, again, this is just a request. Congress ultimately decides, but the Trump administration has asked to eliminate funding for UNICEF, or the account that provides that funding. It doesn't specifically say that we're not going to give any funding. They're trying to create an entire new account that they can decide to provide funding to various areas, but the traditional funding stream that the administration would use to provide the core contribution to UNICEF, they're proposing to eliminate that. At the same time, in addition to just core funding, the US uses UNICEF, as you've discussed, for the implementation of various programs, and all of that's probably on hold right now. And since they're proposing to significantly eliminate global health funding, as Shiza mentioned, it's likely going to have a significant impact on that work. Back to the question, Jason, on what's the likelihood of European donors. And I think I saw a question there from Carl about the donors that might have stepped up in 2017 to fill the cuts that were being proposed by the first Trump administration. What's the likelihood of that happening now? That's the big question. A lot of these donors, as I had mentioned, have announced that they're cutting ODA. So if they're going to support family planning at a higher level, what other areas are going to get cut? But this has all happened so fast, right? So could there be pivots? Could there be changes by some of these donors? Certainly, to the extent of filling $600 million a year. I think that's a pretty heavy lift. And it's, who could possibly, with reduced resources, fill that hole? I think it's probably unlikely. But it is something that we'll be tracking over the months to come as additional information is made available, as we know more about Congress. Are they going to push back against the administration? And are any of these donors really going to make that kind of jump that they did in 2017? And we'll be including anything that we find or any kind of those assessments with our next report in the fall. So I'm sorry I don't have more specifics. The donor overall pie of total funding, I think, is about half of the global investment. So when you look at half the global investment and 40% being the US, that's a big chunk to fill. But there's certainly possibilities out there. Hopefully that I answered that question. Anything else along those lines, Jason?
No, I mean, I think there are questions about fiscal space and what, do domestic governments have the fiscal space to increase their spending to make up this gap? I think depends on the country. I think it's very dependent on country, and certainly we know that many of those countries that were most dependent on USAID resources are the ones that are that have the least ability to, or the least fiscal space to fund their own programs. I do know, and I do know we have some experts in the webinar on the commodity and supply side. For those of you who saw some of the work that we previously did on the USAID terminations and what it means for family planning, of that 600 million, I think we estimated approximately 10% of that, or 60 to 70 million, were directly purchasing commodities. Martin's here. Thank you, Martin. 61 million. And Martin, there is a question in the chat about commodities and supplies and what's being done to understand those gaps. And I think you and colleagues could probably chat there and talk a little bit about the near-term work to ensure that commodity and supply are secure, and that supply chains or supplies are getting the last mile. I'm not going to try to answer that on your behalf. And so if you want to type something into the chat, please do so. Doing my best. You got a lot of great questions here. So maybe a question for Shiza on unmet need. There's a question here about measuring unmet need and generating data on unmet need. We didn't really talk about that in HMIS systems or LMIS systems. Can you say a word about, if we didn't have the DHS and didn't have the mix, what would we be able to do, if anything? And you might, I see you with a grim grin there. So perhaps the answer is that we can't, but go ahead and fill that in.
Well, the answer is, as of right now, we cannot calculate unmet need, which is dependent on several other questions within household surveys around fertility intentions and spacing and use. So it's not a single question indicator. So it will be hard. But as of right now, I'm not sure of any HMIS system that allows you to get to a proxy indicator of unmet need. But Priya can correct me.
I can't correct you. That's right. But I will say that we can produce estimates for the next few years with great uncertainty on unmet need using modeling. But I don't know if that was the question.
Well, I think you're right. So then that unmet need would be based on the latest surveys. It sort of builds over time, our uncertainty. So as we get further and further from our last data point with those models, our uncertainty gets wider and wider. And so a great question from an anonymous person. Thank you. So there are some questions about, and I'll open this up to anyone really, beyond advocating for restored funding, what are you all thinking about in terms of ways to help countries to navigate reduced resources? Priya, you mentioned that countries, in your survey, you were asking countries what they were using to respond in terms of data. And Shiza, I know that we've had some thoughts about and requests from countries regarding helping them understand funding losses and responding. So welcome any responses there. I know this is a tough question and something we may be answering over the next many months, if not multiple years. Go ahead, Priya.
Right. I think what we've seen where there has been success, or not success, but what countries are doing, some of them are actually quite interesting. So the ones that seem to be the most interesting in terms of resilience for the future is about that shift to insurance. Interestingly enough, most people did not mention insurance as a way, social insurance schemes that have already been, started, they're nascent, they may have difficulties, but this is the instrument through which financing for health at the country level, at least for people with limited resources, are going to use. And if family planning needs to be, the capitation, the costs for family planning have to be properly structured in these insurance schemes, and both long-acting permanent methods, services, right? We see that in many countries, the private sector is completely disengaged in terms of providing high-cost methods. So having a think about that is going to be important. And then I think the other piece in terms of data, I really do think being aware that going through a primary, being aware that it's the primary health system that's going to be sort of the backbone, and making sure that FP data elements and indicators stay, and people prioritize. I mean, I think the fundamental thing is this is actually can also be seen as a moment to rethink the program. Should they be doing all these activities, or is it more important for those women that you actually use your public monies that's so limited and build off the investments that have already been made through other health programs? So taking the moment to rethink this. So one country, a couple of countries have actually done some interesting things in the wake of what Adam was talking about, those secondments, things disappearing. This was Zimbabwe. They've come up with at least a scheme. And their point, as you saw in my slides, was, look, we're used to shocks. We've had this huge round with FCDO before. We know how things work in a very resource-constrained environment. And what they've done is all those people losing jobs, at least that's what they're thinking about, through the especially skilled personnel, through HIV doctors, nurses, trying to absorb them a little bit into the public sector so that clients will continue to get some access to skilled labor. And similarly with method mix, they're shrinking, moving towards, high moving products that don't have huge logistics costs, like pills and condoms. So these might be some of the strategies in the immediate near term that they might be trying to, countries might try.
Thanks, Priya. I think we're certainly working with our hubs to understand impacts, understand the data requests and data needs that countries have for prioritization, and then thinking about how we support those countries to prioritize in a new resource scarce environment. Priya has talked about a few in the financing space, as well as service delivery. But I think this is an active question that we all need to be working towards, and so thank you. Just getting back to the question and answer. And I will say that in terms of extracting, I think there was a question from Catherine Church here about extracting lessons from middle income countries. Either those that may have never been supported through USAID in a large way, or some, for example, from Latin America that saw graduation in the late 90s and early 2000s. I will say, I think there's a great opportunity with ICFP being in the LAC region in the year, towards the end of this year, for us to facilitate some learning about how the LAC region, which saw pretty stark and quick reductions in USAID funding, how they adapted, both in positive and potentially not so positive ways. A more vibrant private sector, a more limited set of methods available. So I think there's a lot to be learned in that space, and I hope that that we can create some of those spaces, both as FP 2030 and as a community. That kind of hints at something that Priya, you were talking about, and she's there was a question from our Monica Kerrigan regarding public versus private sector data. We are trying to, we do have plans to learn from certainly MSI, a direct and great partner of ours, on changes they see in their private sector service uptake, as there may be reductions in the public sector. Perhaps you can say a way in which we interact with MSI, and then Priya, perhaps you can say availability of private sector data in the HMIS systems. Some countries, yes, some countries not so much. And I think with those two questions, we'll probably close it out. So let's see if we can get quickly to those. Shiza.
Sure, I'm happy to answer how we interact with MSI. So MSI is on our Performance Monitoring Evidence Working Group, which is a group of family planning measurement experts. And in the past, when we've had disruptions to healthcare systems around the world, especially during COVID, we really relied on service provision data from partners like MSI to show the disruptions and then to show how countries were able to adapt and serve a growing number of users. So we're hoping to work with our partners at MSI again to see and review what have the impacts have been at the country level in terms of service provision for women and girls around the world. Priya?
Thanks, Shiza. Go ahead, Priya.
Sure. Jason, you answered the question really. Many countries don't have really a full catch of the private sector. What's interesting in the Ethiopia case, for example, is that everyone, now they've got all their private sector's facilities mapped with the right names. They're also given an ID when they register to get their registration of their license. So that's one way to make sure the data is captured. Because otherwise, what we found from even analysis that we've done in Kenya, for example, that you train them, the private sector, to report, but the incentives aren't there. The incentives are simply not there for them to report. So unless the entire system is the governance and the interest in getting private sector involved and engaged is there, it's going to be very the other kinds of attempts to bring pharmacists in or some clinics in is pretty haphazard and doesn't really last very long.
Thank you. So thank you to everyone. I think we're approaching the end of our 90 minutes together. I want to just say a huge thanks to all of you for, I know the incredible work that you're doing in a difficult moment to respond to all of these impacts on our field. And I recognize that many of you are tuning in without a clear situation, work situation, and without clarity on how you will continue, but you are committed to this field. All of us are committed. We will be working over the coming months to gather our next release of data. We anticipate having that available in some form for the ICFP. We are collaborating closely with ICFP to support these conversations, both on measurement, on learning, on the role of the private sector. And I want to say we're also spotlighting our need to continue to advocate for family planning through our Made Possible campaign, which I hope colleagues of mine can share in the chat. A special thanks to our presenters today. If you can take me off spotlight so I can thank Shiza, Adam, and Priya. Priya joining us late night from India. Thank you, Priya. And just to say, it's always a pleasure to work with these data partners, with all of you to learn about the impacts. And I hope that you will help us help the family planning community to understand where we go next, how we adapt, what we learn about the impacts on particular populations, and to develop a resilient response like we did in the dark times of COVID. Thank you, and I hope you have an excellent rest of your evening, afternoon, morning, and thanks. Goodbye.